So now we'll go through the atrioventricular septal defect with both atrial and ventricular level shunting, or the so-called complete AV septal defect. Again, we're looking at the rightward aspect of both the interatrial septum and the interventricular septum, and we see this large scooped out AV septal defect. If we removed the valve from this AV septal defect, again, you wouldn't be able to tell whether there was exclusively atrial level shunting or a partial AV septal defect versus both atrial and ventricular level shunting. So it's the position of the valve within the AV septal defect and its attachments to the crest of the muscular septum, along with the presence or absence of a tongue of tissue between both superior or both bridging leaflets, that determines the degree of both atrial and ventricular level shunting. So looking at the interatrial septum, we see that the oval fossa is intact. There's no atrial septal defect, and the leading edge of the primary septum is thin, the unmuscularized mesenchymal cap, which has not fused to the endocardial cushions, creating this large scooped out AV septal defect. The superior bridging leaflet has attachments to the crest of the muscular interventricular septum, but you can easily see that there's elongated chordae with large spaces between the chordae, allowing ventricular level shunting. There is no tongue of tissue between the bridging leaflets, like we saw in the defect with exclusively atrial level shunting. And then looking at the inferior bridging leaflet, we again see attachments to the crest of the muscular septum with elongated chordae and spaces between. So there's ventricular level shunting both within the chordae underneath the bridging leaflets as well as between the bridging leaflets. And then there is large atrial level shunting above the leaflets. So this heart is different, but often confused with AV septal defects. We see the floor of the oval fossa. There is a small secundum ASD. There's deficiency in that primary atrial septum. We see the leading edge of the primary atrial septum looks much more thickened. It has muscularized. The mesenchymal cap has muscularized in the vestibular spine, and it's attached, fused with the endocardial cushions, septating the atrioventricular septum. So now the atrioventricular septum is the small portion of the membranous septum at the triangle of Koch, at the apex of the triangle of Koch. So much smaller than the deficiency that we see in the atrioventricular septal defect. So this is not an atrioventricular septal defect. However, if we look underneath the tricuspid valve, so here's the septal leaflet, the anterosuperior leaflet, and then a portion of the inferior leaflet has been transected. Here's the other portion. So it's a trifoliate right AV valve, and underneath the mouth of this AV valve, of the septal leaflet, is a inlet VSD, and it goes right up to the attachment of the tricuspid valve, and it extends anteriorly into the central region towards the base of the heart, or the perimembranous region. And if we look to the left side, we can clearly see here's that septal leaflet attachment, and it's in fibrous continuity with the aortic valve. This is a perimembranous inlet ventricular septal defect. So different than a atrioventricular septal defect with exclusively ventricular level shunting. Another difference is the left AV valve. Here is the anterior leaflet of the left AV valve. It's in fibrous continuity with the aortic valve. And then if we look towards the posterior leaflet, which has been partly transected, here's one portion of the posterior leaflet. Here is the other portion of the posterior mural leaflet of the mitral valve. We can see that there's only two leaflets of the left AV valve. It is a mitral valve, and it's devoid of any septal attachments. So a perimembranous inlet VSD, which is different than a atrioventricular septal defect with exclusively ventricular level shunting. Now this heart, again, will open from the right side, looking at the rightward aspect of the interatrial septum here in the ventricular septum. And this is interesting compared to the other atrioventricular septal defect, because here we see a thin strand, a remnant of the leading edge of the primary interatrial septum. Right here. And above that is the floor of the oval fossa, which has little fenestrated deficiencies throughout it. We see the limbus, or secondary septum, guarding the roof of the oval fossa with its deficiencies. So there is both a fenestrated secundum atrial septal defect, or oval fossa deficiency or defect, and there additionally is an atrioventricular septal defect on the anterior aspect of this leading edge of the primary atrial septum. If we look at the atrioventricular septal defect, we see the superior bridging leaflet, which has attachments to the crest of the ventricular septum. However, there's chordal space, there's interchordal space between, allowing at least small to moderate ventricular level shunting. There's no bridging tissue between the superior and the inferior bridging leaflets, and then again the inferior bridging leaflet also has attachments to the crest of the muscular interventricular septum with spaces between the chordae, allowing ventricular level shunting in addition to the larger atrial level shunting, as well as this fenestrated secundum ASD. So both this and the prior heart with the prior atrioventricular septal defect, both having attachments of the superior bridging leaflet to the crest of the ventricular septum, would be classified as Rastelli type A. Now looking at another heart from the rightward aspect. This one's a little more difficult to open up. We see the limbus over the oval fossa. We do see a deficiency in the floor of the oval fossa, a small secundum ASD. We see the leading edge of the primary atrial septum, and we see a large scooped out atrioventricular septal defect. Here, however, the superior bridging leaflet is free floating. It has no attachment to the crest of the muscular interventricular septum. The inferior bridging leaflet here does have attachments to the crest of the interventricular septum. The Rastelli classification is based on the attachments of the superior bridging leaflet. So this is a free-floating superior bridging leaflet. If we come over to the leftward aspect, you can again appreciate here's the superior bridging leaflet. It's free-floating across the atrioventricular septal defect. So this is a Rastelli type C defect. We look at the interventricular septum, and I want to point this out to compare to the next heart, and we look at the normal septomarginal trabeculation coursing from the apical trabecular portion. At its base here is cut the moderator band, coursing up towards the outlet and then dividing into the anterior cephalid and posterior caudal limbs of the septomarginal trabeculation, with a supraventricular crest within its limbs, and the outlet septum, which in this heart is not really distinguishable, in the freestanding muscular sleeve or infundibulum leading up to the pulmonary arteries. And we see the septal parietal trabeculations coursing from the septal marginal trabeculation to the parietal or free wall don't look that prominent. There's no obstruction to the right ventricular outflow tract. However, looking at our last specimen, opening it up from the right ventricular aspect, so this is a very large heart. We can see here is the limbus or secondary septum, we can again appreciate that it's no more than an infolding. It's not a true septum. Here's some fat, epicardial fat within this infolding. And then in the floor of the oval fossa, there's multiple deficiencies or fenestrations. So cumulatively a moderate to large shunt from a secundum atrial septal defect. And then here is the leading edge of the primary septum, again thin and not muscularized. It has not fused with endocardial cushions. Here's the crest of the muscular interventricular septum, the superior and inferior bridging leaflet. So this is an atrioventricular septal defect with both atrial and ventricular level shunting. And the superior bridging leaflet again has no attachment to the crest of the ventricular septum. It's free floating. It's a Rastelli C. The inferior bridging leaflet does have attachments both to the right side of the interventricular septum along to the crest, and there's not much space underneath this leaflet for shunting. However, because there's no tongue of tissue between the bridging leaflets, and because there's a free floating superior bridging leaflet allowing shunting, there is a large component of ventricular level shunting along with atrial level shunting. However, when we compare this to the prior heart, which was also a Rastelli type C complete AV septal defect, or AV septal defect with both atrial and ventricular level shunting, if we look at the interventricular septum on the rightward aspect, we see a very prominent and hypertrophied septal marginal trabeculation. And we see a very prominent moderator band which has been cut, which would course across to the free wall of the right ventricle. And coming up the septal marginal trabeculation, we see that there is deficiency in the posterior caudal limb. The atrioventricular septal defect is confluent with a perimembranous defect. And if we look at now, here is the posterior or the anterior cephalid limb, and the outlet septum is much more pronounced in this heart. It has been divorced from within the limbs of the septomarginal trabeculation. Here's the outlet septum. So it's been divorced from, here's the anterior cephalid limb. It no longer resides within the limbs, with the posterior caudal being deficient, but it's been divorced from within the limbs and it's anteriorly deviated. So this is a perimembranous outlet defect with anterior deviation of the outlet septum. So you have both a complete AV septal defect, Rastelli type C, which is confluent with, it has outlet extension. So there's an additional perimembranous outlet defect with anterior deviation of the outlet septum. And if we look at the septoparietal trabeculations coming from the septomarginal trabeculation, they're much more pronounced and hypertrophied. And if we look at the infundibulum, there is severe obstruction related to this anteriorly deviated outlet septum. Here's the pulmonary valve. The pulmonary valve itself looks bicuspid. So there is significant subvalvular obstruction related to this anteriorly deviated outlet septum, along with these hypertrophied septal parietal trabeculations, along with some degree of pulmonary valve stenosis related to this bicuspid pulmonary valve. So again, this is both a AV septal defect and also a tetralogy of Fallot.